for those who may have slipped in during the day, I'm Julie Bynum. I'm one of the NPIs of the Coordinating Center who's put together this meeting to share with all of you. And we're moving to our afternoon panel. We're shifting gears a little bit. This morning, we've been talking about caregiving and long-term care, one of the two most costly parts of care provision for people living with this disease. And now we're moving to the medical care. This panel will be all topics related to the healthcare system, medical care system, which is the other most costly segment of care for people living with dementia. So we're very happy to have three, I believe you're all the PIs of RO1s that are part of this consortium, which is terrific, making up this panel. I'm going to refer you all to the program book for details of everybody, but I wanted to just start out with a bit of a comment just because of Jay Bhattacharya's comment to say that the transition, a lot of my work, most of my work that people are aware of, at least, is in the healthcare space related to Alzheimer's disease and dementia. And on the comment about someone's first paper, one of my first two papers was about the risk of hospitalization among people with Alzheimer's disease and dementia, related dementias. And that paper, the point that I made was no matter how you risk adjust all the different ways to do comorbid conditions, dementia itself is associated with double to triple the risk of hospitalization. But in that paper, we didn't leave it at that. We asked the question in the discussion, why? If you have a heart attack, you need a cath lab. You need to come to the hospital, right? If you have a pneumonia that's bad enough, that's not getting better, you need intravenous antibiotics. So you need to come to the hospital. But in people with dementia, what is the service that's being delivered in the hospital that puts them at risk? That was the question I asked. And I know Matthew Baumgard, who's associated with the Alzheimer's Association, knows that paper well. He's used it many times because it really pushed our notion of one of the things that push our notion of this disease from one of long-term care, where we can look aside and pretend maybe that this environment doesn't exist, to one where it really drew attention to the Medicare system to say this is actually also a healthcare issue. We're not doing well in managing this population. What do we need to do? And from there. So that is my way of transitioning. I think that paper for me, which was maybe my most creative paper, I don't know, I'll have to reflect after I go home tonight, was really saying, hey, what this group of people really need is great care from families, from long-term care systems, quality healthcare. But what we're seeing as an outcome is what's happening on the medical care side. So lots has happened since then, and we're going to turn this over. The first speaker is Cyrus Kosar, who's an assistant professor in the Health Science Policy and Practice Department of the Brown University School of Public Health. I said, please look at the full program book full description. And Cyrus, come on up. Oh, it changed. Yes. Yeah.
All right. Thank you for having me. I just want to quickly say that I don't have any conflicts of interest to disclose, and the funder of this work is the NIH. The same as Julie mentioned, this is an R1 that was selected to be part of this consortium, and the content presented doesn't necessarily reflect the views of the funder. And I just want to quickly acknowledge my collaborators, Shantu Raman, Betsy White, Dave Grabowski, Brian McGarry, and Fong Li Gang. So we have a good mix of health economists, people who specialize in health policy, and Betsy and Brian are actually clinicians who have practiced in nursing homes, which is actually the subject of today's talk. All right. So about 1 million individuals receive long-term care, and about 15,000 nursing homes nationwide, and about 75% of long-term care recipients in nursing homes have dementia or some sort of cognitive impairment. We consider nursing homes to be safety net providers because they distinctly service very frail populations, populations that are disabled both cognitively and physically, and also disproportionately impoverished. So this, of course, raises the stakes of the delivery of care, ensuring that it is high quality. But unfortunately, as most scholars who have studied nursing homes can tell you, variable quality of care has been a persistent issue, even though the high health risk of this population places them at greater risk for adverse outcomes. There's a large literature documenting high rates of avoidable hospitalizations and other outcomes such as pressure injuries, psychotropic medication use that are sensitive to the delivery of care. There's also suboptimal end-of-life care in nursing homes. About 12% of residents with advanced dementia are hospitalized in the last 30 days of life. Feeding tube placement rates are also very high and reflect some sort of discordance with clinical guidelines. And if you ask scholars like why this is the case, most would tell you two things. So the first is that Medicaid, which is the largest payer of nursing homes services, the largest purchaser, also reimburses the least. The second is that there's discordance between Medicare and Medicaid, conflicting incentives, and a lack of coordination. So to give you an example, Medicaid reimburses nursing homes for the nuts and bolts of long-term care, which is room and board and personal care needs, but Medicare pays for everything else, including primary care, acute care, post-acute care. And the rates that Medicare pays nursing homes to provide post-acute care under the skilled nursing facility benefit are much higher than Medicaid reimbursement rates, and that to access the skilled nursing facility benefit, residents need to be hospitalized for at least 3 days. So some scholars attribute this to at least partially explaining higher hospitalization rates. Another issue is that nursing homes don't really internalize any savings from reducing hospitalizations. So the institutional special needs plans, or ISNP model, is an alternative financing and delivery of care model that may be a promising a model of care for nursing home residents with ADRD. There are two broad features of ISNPs that are important but not actually distinct to this plan type. So one of them is that they receive fixed per member per month payments from CMS to finance Part A and Part B benefits. And this capitated financing obviously incentivizes more efficient utilization, and incentivizes plans to really coordinate with providers to substitute away from more expensive types of care. There's obviously the concern that capitated financing could also lead to reductions in necessary care, of course. Now, ISNPs are also, like other special needs plans, required to develop and administer a Medicare-approved model of care. Now, the difference is that ISNPs can only exclusively enroll nursing home residents, so that model of care is going to be really tailored to the nursing home setting. So where ISNPs come from is they actually originated as a demonstration project known as Evercare in the late 1990s, and this was purchased by United Healthcare, and eventually it was rebranded as the Optimized SNP, or United Healthcare Nursing Home Nursing Home Health Plan in the mid-2000s after the Medicare Modernization Act. And there's like three main features of this model of care. And so one is the employment and actual deployment of advanced practicing clinicians, namely nurse practitioners to nursing homes. And with the stated goal of coordinating care with nursing home existing in-house staff, promoting advanced care planning, and also helping with the treating acute illnesses in place. And to do this, and the second key feature, the United Healthcare Nursing Home Choice Plan waives the 3-day hospitalization rule so that care, and they pay nursing homes a skilled care rate to treat in place. And then the third key feature is that there's shared savings with nursing homes from reduced hospitalizations. I don't mean to sound like a spokesperson for United Healthcare. I certainly am not. But the reason I'm focusing on it is because it is like the most well-known model of care. But there are questions about its efficacy advocacy. This is what is on paper, but there may be heterogeneity across nursing homes and how it's implemented. So the overall effects may not be particularly good. There's also increasing numbers of alternatives to the United Healthcare iSNP. So in recent years, on the left graph, you can see the number of iSNP plans, and the red bars are United Healthcare, and the blue bars are other iSNPs. And so you can see a large number of these other iSNPs cropping up. They still don't account for the majority of enrollment. United Healthcare still does, but recent enrollment growth, which is the right panel, has also increased for these plans. So what we want to know is, like, is there a better alternative to the United Healthcare plan, or are these, copycat plans that don't do a better job? So these are the empirical questions that we're going to be answering today. And this graph, what I'm showing you, is the proportion of nursing homes that participate in the iSNP program. In 2021, it looks like under 25% of nursing homes have an iSNP. So formally, our objective is to examine the impact of the United Healthcare and non-United Healthcare iSNP enrollment on hospitalizations and other adverse care outcomes among nursing home residents with ADRD. So iSNPs are recently in the news. I don't know if anybody saw this Guardian article, but basically, if you take the worst possible interpretation of everything I said, they called the shared savings a kickback, and maybe this is true. This is an empirical question. Now, there are certain limitations of administrative data that aren't going to allow us to observe some of the things that are discussed, right? But this is a very timely subject. So we primarily rely on Medicare administrative data. These data sources will be very familiar to anybody who's worked with that data. Medicare beneficiary summary file is like an enrollment listing of all active Medicare beneficiaries in a given year. MedPAR and Medicare Advantage encounter data are healthcare claims data. The minimum data set is a nursing home clinical assessment that is administered to residents when they are admitted and serially thereafter until they're discharged or they die. And we also use public, SNP enrollment reports. Our cohort was new nursing home admissions, so people who weren't living in the nursing home already, people who were admitted and they stayed there for at least 100 days, which most people who do long-term care research use that as the cutoff for defining who is there for long-term care versus there for other skilled care needs. And the years of data analysis are 2016 to 2022. We followed everybody who met this criteria for each quarter during the study period, and we required them to have a diagnosis of Alzheimer's disease or related dementia. We use the claims. I'm already at 5 minutes left, so I feel like I'm not a Zoom. We use claims and MDS data to help ascertain that. And our final cohort was about 12 million person quarters. So our main explanatory variable, obviously our treatment effect that we're interested in, is iSNP enrollment, but we also do iSNP type, right? And we also stratify analyses by payer at the time of admission. And this is really important to be able to distinguish between the effects of Medicare Advantage more broadly from this iSNP enrollment itself. And our main outcome is hospitalization. We look at these other cost of care measures. And we use a variety of demographic and clinical health controls in our regression models. And we also use nursing home fixed effects, which are pretty critical for our identification strategy. So we can begin with a little simple specification where we estimate hospitalization for individual I in facility F at the time in quarter Q of year T as a function of iSNP enrollment and the covariates I previously mentioned. The parameter of interest, or beta 1, is likely to be biased. It's going to be really difficult to identify because of non-random selection into iSNPs, both at the patient level and the facility level, although the facility effect kind of makes us worry about that just a little bit less. So what we do is we instrument for ISNP enrollment with ISNP availability. This isn't actually a very good instrument if you just use it as is, because ISNPs are going to locate in areas that may have better health status or more or less lower poverty rates. But that nursing home fixed effect allows us to exploit variation in access to ISNPs within the same nursing home based off of the timing of ISNP initiation, and as well as like the timing of when you became a resident. Now, we estimate the instrumental variables model through just two-stage least squares, and the identifying assumptions are that ISNP enrollment increases after availability, and that there's no underlying changes in health status associated with ISNP adoption within the nursing home, right? So in other words, if that's the case, the exclusionary restriction would be violated. So I'm not going to walk through all these sample characteristics, but the key takeaway is that if you just look at the characteristics of ISNP enrollees and non-enrollees, you can see that ISNP enrollees are actually healthier. So that idea of health status-based selection is like very real. Here's ISNP enrollment for people who entered in as Medicare Advantage enrollees at the time of admission and traditional Medicare enrollees at the time of admission. You can see it's the ISNP take-up rate is higher for people who are originally MA, but there's a substantial number of TM enrollees who do enroll into an ISNP. So we had a really strong first stage, as you would expect given this graph. Our F statistics were in the 3000s, but this just shows what ISNP enrollment looks like in the years before and after a nursing home initiates it. So 8% enrollment in the first year and about 25% on average in the second and third year. So to get at like this, to kind of do a falsification test to kind of assess the exclusionary restriction, what we did was we just estimated the probability of ISNP enrollment as a function of all the observables, and we held out, ISNP availability, and then we took that predicted probabilities of ISNP enrollment and looked at them over time before and after nursing homes initiated the program, and we see that this like observable based probability of ISNP enrollment doesn't really change very much. And then this is a table of a bunch of estimates, but what I want to tell you was basically ISNP enrollment was associated with about a 3 to 4 percentage point reduction in the probability of being hospitalized, and that's true for United Health ISNPs as well as non-United Health ISNPs. We also found that there was no really strong evidence that any of the other process of care measures, pressure injuries, psychotropic medication use was impacted. These findings are also pretty consistent with ISNPs also have very low disenrollment rates. So the data are suggesting that this is probably a pretty good model of care. Although I can't tease out the terrible things that were described in the Guardian piece, and there's always the possibility that I didn't get the selection issue addressed properly. And lastly, I just wanted to say this is a good program, it seems like, and the ISNP enrollment is increasing over time, but take-up is still overall pretty low. It's about 9% of all nursing home residents are enrolled in this type of plan. So I think that we need to do a little bit more research on barriers to take up and also whether the program can actually scale. All right, I'm on time.
Introduce from here. Thank you, Cyrus. That was terrific. Our next presenter is Amresh Hanchate. Hanchate, thank you. Professor of Social Science and Health Policy from Wake Forest University School of Medicine. And by the way, while he's getting that going, be jotting your questions down so that you're ready when I open the floodgates, but you're ready.
Good afternoon, everyone. It's a pleasure to be here to present some of the early findings from our project on home-based medical care and telemedicine in ADRD. So in some sense, we are moving from inpatient to the community setting for ADRD here. First, I'd like to acknowledge funding from NIA and my excellent collaborators at Wake Forest, Johns Hopkins, and UPenn. And Stephanie Nuttall and Bruce Kinosian are here today to help me out in case I get stuck. The introduction of legislative waivers in March of 2020, following the COVID-19 emergency, allowed clinicians to offer telemedicine as an option. And instantly, there was a spike in telemedicine use, followed in subsequent months by gradual decline up until the second quarter of 2021, where we see there was some stability in use of telemedicine to about 15 to 18% of Medicare enrollees using telemedicine. Let me at the outset say all the numbers today I'll be showing you are all in the traditional Medicare space, in case I forget to mention. Research following this expansion, particularly in the general Medicare enrollee space, has found that largely telemedicine has substituted for office visits, with really no change in overall visits. Given our ADRD interest, we asked a slightly different question. How did telemedicine expansion affect users of home-based medical care, which is basically house calls by doctors? This is a significant issue. A large portion of people diagnosed with ADRD and living in the community are at high risk of becoming homebound with advancing disease and worsening impairment. And so access to house calls is pretty significant. And from a policy perspective, it also has a significance for advancing the goal for aging in place, if you will. Let me start off with some basic information about home-based medical care, because at least when I got into it, I didn't know that much about it. And I feel like it hasn't been written about much. As I mentioned earlier, it's when a clinician visits the patient's home or an assisted living facility. Medicare has covered house calls for a long time, although the volume of such calls has been generally low, about 7 million in 2019. And just as a point of reference, the same year, there were 251 million office visits. A small fraction of these house calls are for post-acute care, but predominantly it's used by the long-term homebound patients. And another feature of house calls is the reimbursement. The reimbursement for house calls for a long time was about the same, but in recent years, it has actually gone below the rates for equivalent office-based visits. And that's important because it, to some extent, explains the sort of rigidity why the volume of house calls has been low in the system. And there is general agreement that the current supply is well below potential demand, if you will. Another aspect, the pathways to enrollees becoming homebound could be multiple, particularly in different conditions. Probably the most significant is a diagnosis of ADRD. It's estimated that about 28% of ADRD enrollees living in the community are homebound. Unfortunately, in claims data, we cannot identify homeboundedness, if you will. But what the data indicate is that among the people diagnosed with ADRD, about 15% had at least one house call in 2019. And even this small group accounted for 2/3 of all the house calls within the system. The type of care provided by house calls is primary care. So this study is going to be basically about looking at primary care visits. And who provides these? Nurse practitioners, as you see, accounted for about half of them. Physicians in internal medicine, family medicine, and geriatrics provided 40%, and the rest came from physician assistants. Availability of providers of house calls varies a lot with location. In terms of hospital referral regions, we see that in the regions in the lowest quartile, there were only 1.5 providers for 10,000 Medicare enrollees. And in the top quartile, it was 10.4 providers. The users of house calls are quite different from the non-users. They tend to be older, more frail, and at higher risk of death. Having said all this, let's come back to my question. In theory, telemedicine expansion could affect home-based care in multiple ways. From a provider side, there may be a cost advantage to substituting house calls with telemedicine. But from the patients, caregivers, and even from the provider's perspective, there may be a preference for house calls. One is the obvious benefit of quality of care preference for home-based care. Having a clinician in the patient's home gives the clinician a much better assessment and ability to manage the patient's conditions, particularly behavioral symptoms. A third possibility is that providers, by reducing office visits, can increase both telemedicine visits and home-based visits. So our question is more of an empirical one. What we are looking at as the main outcomes are the number of primary care visits among those with ADRD and living in the community. We look at this separately for house calls, HBMC visits, telemedicine, and office visits. We used claims fee-for-service claims data from 2019 to 2021 and calculated the counts of each of these visits by quarter, separating the pre-expansion period and the post-expansion period. Comparing users and non-users is problematic. As we just saw, they're very different. So to better identify exogeneity in house call use, we used area, region level availability of providers and stratified all the ADRD enrollees into those living in low provider areas, low HBMC provider areas. That's the quartile one we saw in the map earlier, and all the rest, calling them high HBMC provider regions. From now on, I'll just call it high HBMC and low HBMC regions. Now, to adjust for regional differences in trends that are unrelated to the needs of the homebound population, we used a second comparison cohort of non-ADRD enrollees who were younger, 66 to 74 years old. So we started with data, nationally representative sample of 932,000 enrollees, and using the CCW algorithm, identified the ADRD cohort, age 66 and older, and the non-ADRD cohort, age 66 to 74. The main estimate of interest was the differential change in the outcome between those in the high HBMC versus the low HBMC regions. We used a linear regression model with a difference in difference specification and individual fixed effects, and also included a number of time varying covariates at the area level, COVID cases, deaths, and number of providers. Coming to the results, we see pretty good balance in the groups being compared. On the ADRD side, we see the enrollees in the high and the low HbA1c regions be similar in terms of age, frailty, and risk of death. Similarly, for the non-ADRD, the comparison cohort. This gives the observed trends in our outcomes. So each panel has 4 lines. The best panel to look at is telemedicine. The 2 blue lines represent the 2 groups in the high HbA1c regions, the solid line for the ADRD cohort and the dashed line for the non-ADRD cohort. And the 2 yellow lines for the 2 groups in the low HbA1c regions. And each, there is a faintly visible shaded two shaded blocks in each panel. The one on the left represents the first 4 quarters. That's the pre-expansion period. And the one on the right represents what we call the late post-expansion. That's the last 3 quarters where telemedicine use had stabilized. And the results I'll present today are basically comparing the change between these 2 periods. Looking at the HbA1c panel, we see clearly that those in the high HbA1c regions had much higher use of house calls. And we also see very little use of house calls in the comparison cohorts. Office visits in the pre-expansion period were pretty similar across all the 4 groups. And so in terms of all visits, the main driver of differences was the actual amount of house calls. Otherwise, they were pretty similar. Our main finding was that telemedicine expansion was associated with much higher increase in house calls in the high HbA1c regions compared to the low HbA1c regions. And this is the change between the pre-expansion and the late post-expansion period. And the estimate there here amounts to a 16% higher number of house calls for the same group compared to their pre-expansion level. And we see no difference, differential change for telemedicine or office visits. I need to speed up quickly here. So in terms of breaking down this change, what we found was much of the change was in the extensive margin. That is, more people started receiving home-based care in the post-expansion period. And the intensive margin estimate was sizable, but not statistically significant. That is, increase in the number of visits among people who were already using home-based care. We have done a number of sensitivity analysis. The findings were robust to using alternative algorithms for identifying ADRD, changing the comparison cohort, as well as propensity score to get our balances in the characteristics much closer. So to summarize, telemedicine expansion was associated with more house calls in regions with more providers. And this happened through more people receiving house calls. And when we took our sample numbers to the national level, it scales up into a pretty sizable number of people receiving house calls in the post-expansion region, post-expansion period. We recognize a number of limitations. COVID-19, as we all know, set off a number of changes in care delivery. And so there may well be changes in regions that could be associated with what we are finding besides telemedicine. And we need to be surely looking at data beyond 2021, and of course, also with Medicare Advantage. Final slide. The implications, what we see is it appears telemedicine expansion had an unintended benefit in terms of access to house calls, at least in ADRD. And the telemedicine, these waivers are set to expire in September this year. And so there is sort of a policy contribution for this evidence, which sides on continuing these flexibilities in the interest of house calls. Unfortunately, another implication is that it points to widening of disparities in access to house calls based on where you live in terms of availability of providers. Thank you.
So making a switch over here, I just want to see how many people knew that physicians still do house calls by a show of hands. And Panosian doesn't count. So some of you may not know there was actually a CMMI demonstration project of independence at home, of people who delivered, people who received their primary care exclusively in the home through what are basically low overhead practices. Just wanted to make a shout out to that. Our next presenter is Lauren Nicholas. She is professor at Colorado University School of Medicine in the Center of Bioethics and Humanities and Division of Geriatrics. And she's really going to talk about something completely different. Take it away, Lauren.
Here's my slides. Okay. Great. I'm going to be talking about an R01 that predates the consortium, but we're using some experimental methods that I'm pretty excited about for hopefully more consortium projects, because this is a great way to deal with very difficult to otherwise identify but interesting questions related to the economics of dementia. And I'm going to be talking about how surrogates make treatment decisions for patients with dementia. This is joint work with Ken Langa, Scott Halpern, and Mario Machas. Okay, so there's a frequent need for involvement in end-of-life decisions. In some of our other work, Julie and I have shown that about 2/3 of older adults will have at least mild cognitive impairment by the time they're reaching end-of-life care. This is going to create need for surrogate decision-making above and beyond any difficulties from the purely medical problems. This can also trigger large numbers of hospitalizations and need to make quick and difficult decisions with limited information. And the default is to provide all care possible to sustain life. End-of-life care is also a major driver of Medicare spending. And it's an area where people's reported preferences around what we're doing don't actually match up very well with the care provided, right? And most people say that they would like to avoid feeding tubes and mechanical ventilation, would prefer to remain at home. This is sort of in contrast to what we see actually happening. There's a new movement towards wrongful living lawsuits. You can sue for anything here, including being kept alive in a condition that we might be inconsistent with preferences. And so we have this idea that surrogate decisions to provide less aggressive end-of-life care could be both beneficial for keeping patients comfortable and sort of consistent with their preferences near the end of life, and reducing spending if that is what the patient actually wants. And so when you look at actual Medicare data, we see lower rates of aggressive and potentially burdensome transfer near the end of life for patients with dementia versus without dementia, but still non-trivial rates of all of these things that we might want to avoid. And advanced directives are often proposed as a policy solution that would enable decision makers to possibly make better decisions when they're acting as agents in these stressful situations. So it's recommended that people prepare advanced directives at earlier signs of cognitive impairment so that surrogates can be prepared. The problem with this recommendation is we don't have great evidence about whether and how these are actually used, whether the framing and words used in the documents just influence surrogate choices or even patient choices. So Scott Halpern has shown that if you give people an advanced directive and say, you know, check if you want all care possible, check if you want comfort care only, people are much more likely to check whatever the first box is. And so really, really concerning that some of these ways we present choice architecture could impact what happens directly. So there's a big question around whether we should be recommending advanced directives as a primary way of influencing end-of-life care, growing literature, kind of actually saying we should not be doing this, right? Preferences may change after completion. Documents may not be relevant. People may be sort of manipulated. Sort of risks people feeling like I wrote an advance directive. I don't have to tell anyone where it is or what I want and how to act on my behalf. And then, of course, your surrogate may fully ignore you. So in the context of these potential problems and trying to figure out whether we should be continuing to recommend advance directives, we conducted a large online experiment where a random sample of American adults were asked what surrogates, and these are going to be a spouse or an adult child, should do for a hospitalized patient. We're asking about a third party to avoid social desirability problems and to further, make this less upsetting to people who might not want to think about a loved one dying as part of their research participation. And we use a block randomization design, which in this large sample allows us to vary a number of things, whether or not the patient has dementia, the patient's gender, whether there was an advance directive, and if so, if it requested all care possible or comfort care, the way the decision is framed in terms of removing treatments that have already been started versus initiating treatment in the future. And then we have some expert recommendations where the doctor says, do comfort care or don't do all care possible. Social norms, most patients in this hospital in a similar condition would receive all care possible or comfort care. And so we had a long ramp up to the full survey that I'm going to show you today. We first learned what we could about surrogate decision making for those with and without dementia in the health and retirement study and linked Medicare claims. There's great stuff in the exit interviews that not enough people are using. Then sort of knowing what we did and sort of the limitations of existing data, we designed a pilot survey where we used the Prolific platform, which was much cheaper, but I think great to think about for pilots. And then we sort of refined and redesigned our full survey based on prior results and Scott and Ken's clinical experience to make sure that we were designing vignettes that were both clinically plausible and easy to understand for non-clinical folks. We administered this using the Ipsos Knowledge Network platform, which is a large nationally representative study of Americans. They do all the things you would like to be accessible. They sample from the full set of post office addresses. They provide computers and internet access to households that don't have it. And they do a whole bunch of screening questions in the beginning. So we were able to design our sample to include a random sample of people who are caregivers for another adult, people who had their own chronic illness or had been recently hospitalized, and then a random sample that did not fall into one of these two groups. And so part of why we do this is we cannot do it in our pilot, and the palliative care docs were like, oh, we can't believe any of this because you're not stimulating the effects of making a difficult decision or being in one of these situations. I feel like palliative care doesn't often tell you that your sample should be suffering more, but we needed a way of getting a group that was sort of more familiar with these exposures. And so this allowed us to sample people who would be relatively knowledgeable about sort of having advanced illness or hopefully thought about it in some of the context of their own care. So we end up with what looks mostly like a random sample of Americans. Not surprisingly, both the caregivers and chronic illness samples are slightly older than those not doing either of those things. And you can be in both of these groups. So not surprisingly, many people who are providing care are also dealing with their own chronic conditions. In our block randomization, where we're sort of setting up these choices of dementia versus non-dementia bedridden, and some of these demographics and context choices that we talked about a little bit before. So I'll skip through this. In all of our vignettes, it was an 85-year-old patient who's hospitalized with a sudden serious illness. They are currently unconscious. There are physically invasive treatments available that will sustain life but not restore health. So if you have dementia, it will not go away. If you're bedridden, you will still be bedridden after receiving these treatments. The dementia patient is unable to communicate understandably, and the condition will lead to death in a few years. The non-dementia patient is also bedridden and cannot move around the house independently, but is normal cognition and ability to speak. When there's an advance directive, it was patient. Then we ask survey questions about things we cannot randomly assign, particularly respondents' own treatment preferences if they were in kind of similar situations. And we're going to categorize people by the most aggressive thing they would want of comfort care that would not extend life, life-sustaining treatments that would restore health, and life-sustaining treatments that would extend life but not restore health. We also collect free text responses about what influenced people's decisions, and those ended up being super interesting. I thought people wouldn't answer the questions, but they wrote us nice essays. Most of what we do is comparing means because it's an experiment that lets us do that. We also have some regressions where we can look at lots of things at once. We're going to focus on two things. The first is whether they recommended life-sustaining treatment or not for the patient, and then in the subset of scenarios where there was a patient's preferences. Finally, we do some conceptual analysis to identify themes that were important, and we're going to kind of describe those in a random sample from the free text. So first, two things to note. Similar to real life data, people were choosing the life-sustaining treatments less frequently for patients with dementia versus without, about 20 percentage points less often on average. This was true when the patient wanted life-sustaining treatments and when the patient did not. And there, wasn't nearly as much of a difference when the person was a caregiver or had their own chronic illness. It made them slightly less aggressive in their recommendations for all patients, but not huge differences when you were informed versus uninformed. One thing that was much more important, the sample we worked really hard to access, was the role of respondents' own preferences. So those with sort of the most aggressive treatment preferences were vastly more likely to recommend the life-sustaining treatments for all patients. And then are they following these advanced directives overall? This was another place where, everything could have failed because people treated this as an IQ question and everyone just said, yes, do what patients would want. But in fact, in about 30% of scenarios, they recommend overruling the advanced directive and choosing another treatment. So things that influenced whether the recommendation was goal concordant or not, as we sort of foreshadowed, the two biggest drivers are whether the patient has dementia or not, and the respondent's own preferences, as well as the way from treatments in all cases. We get a little bit of improvement and concordance when the doctor recommends it, or hospital norms encourage it, but not sort of huge differences. And these effects we're able to get from respondent patient concordance or lack of concordance is actually much larger than the differences we see in recommendations for those with advanced directives versus without. To give you a sense of the qualitative data, we ask people their motivations. They say things like, Mr. Jones has dementia and is not expected to live but a couple more years. If it were me, I would hope that I would be kept comfortable but not incubated. We think they meant intubated, or on a feeding tube. Yet life is precious and we should not try to end it on its own accord. It's God's role to extend or end a life. These things, if it was made before, they should know them well enough to decide how they would want to handle. If the doctor made the recommendation, they should be the less resource used option. We kept original text if you're wondering why it's clunky. And then I believe in honoring the wishes of the patient, which is sort of what the bioethics recommendation would be, and something that did not pop up as often as we might have thought it was without looking at the text. So when we look at statements that influenced concordant versus non-concordant recommendations, the most commonly expressed sentiment was actually the respondent's assessment of the patient's quality of life. And those who were concordant were more likely to value respondent wishes. But again, neither of these are coming up to like 100% of people. So patient preferences were the primary driver. So in conclusion, I have no seconds, but we see less aggressive care for dementia, not infrequently ignoring patient preferences and having this really strong role of decision maker preferences that sort of suggest actually talking to your potential proxies and making sure that you're picking someone who would match up with you is potentially a much better solution than just preparing the written advance directive. And I'll stop there.